good to have you with us in this edition of the Urban Debate. Viewers, tonight, one more time, we are back with the COVID vaccine tracker and all the updates related to the COVID vaccine, not just in our country, but from across the world. And of course, today, the biggest talking point has been United Kingdom's decision to give approval to the Pfizer-BioNTech vaccine. And UK will be using it. An emergency approval has been given. Shortly, the rollout will begin. And of course, like any other part of the world, it will take some time before a majority of people are vaccinated. That being said, it is a big news that it's the first Western world country that's given an approval to a COVID vaccine. It's also the first country to give the approval for the Pfizer-BioNTech vaccine. And of course, now it's triggered and reignited hopes of a vaccine reaching all of us sooner than later. But a word of caution. As always here, we get you the facts, we get you the details. We help you understand, does it really mean good news for India? If you're looking around you and you're watching news, it says, well, the COVID vaccine is here. Is it really here for us? Does this vaccine make sense for us? Is our government even looking at this vaccine? Because the last we checked, our government was very clear that the Pfizer-BioNTech and even the Moderna vaccines aren't really suitable for our requirements. And the government is actually betting big on the 5 vaccine trials and partnerships where India is involved. And we are hoping one of these get their trials done soon, find the solution and get the approval from the government. So that's going to be one aspect of what we talk today. The other aspect is the controversy that erupted, as per many, when the government yesterday said that they don't have plans to vaccinate the entire population. And many are saying, but well, the Prime Minister said everybody will get the COVID vaccine. In fact, we'll provide it to the entire world. I think there is some amount of also misunderstanding by what was being communicated. The fact of the matter is, viewers, many experts believe that you don't need to vaccinate the entire population for the infection chain to break. That's one aspect of looking at it. Of course, we would want the government, one assumes, wants that everybody gets the vaccine at some point. Well, what do you need to do to ensure that the infection isn't such a grave threat as it is today? There is a distinction there, and we have experts who will help us understand that. And then, of course, we'll also talk about what should our government's policy be. Should they be free of cost, be vaccinating the entire population at some point? Should they actually be targeting a specific group? What percentage of our population really needs to get vaccinated for us to break the chain and heave a sigh of relief? Vaccinating the entire population could take years. It's not going to be an overnight development. So these are the 2 big talking points that we're going to talk about this evening. Let me say good evening to the big panelists who are joining us. Dr. Sanjay Pujari, Director for the Institute of Infectious Diseases, Pune, and a member of the National COVID-19 Task Force. I also have Dr. Bhramar Mukherjee, Professor for Epidemiology at the School of Public Health from the University of Michigan, joining us this evening. Dr. Virender Singh Chauhan, Emeritus Professor at the International Center for Genetic Engineering and Biotechnology, joins us this evening. Dr. Rakesh Mishra, Director for the Center for Cellular and Molecular Biology, or CCMB as it's known as, from Hyderabad, joins us this evening. And always good to have Sujata Rao as well, former Health Secretary, with us this evening. Let me just first up go across to Dr. Bhramar Mukherjee. Dr. Mukherjee, let's first understand the approval that has come into place for United Kingdom. Does this encourage other countries to look at Moderna, to look at Pfizer-BioNTech vaccine more seriously, to fast-track the approvals there? Give us a sense of how we should really interpret this development.
Thank you so much for having me on the show. I am not a vaccine expert, so I never overstep my scientific boundaries. So I have been consuming the data as a statistician and a data scientist, and trying to give my layman's perspective of as a data consumer, not as an expert. And I think that it could not be better to end 2020 on the note of talking about 3 very promising vaccines worldwide. and the Pfizer and the Moderna vaccine showing very high level of efficacy. We have to still watch out for the safety data, but I think that with the large-scale clinical trials that we have seen, people feel fairly confident about the efficacy. And when the vaccine is rolled out, we have to watch out for the safety and also effectiveness of the vaccine, because clinical trials are a microcosm and we have to see how does it do in the real world. And also right now is the vaccine distribution strategy that's relevant and front and center in every policymaker's mind, that who is going to get it first. The health workers, the frontline first responders, and then the high-risk individuals with comorbidities, individuals ages 50 plus. And then what are you going to think about the COVID survivors and people who have asymptomatic diseases and sero studies? How are we going to distribute the vaccine in a hierarchical way? And for countries like India, where there is not a digital framework to identify who is at high risk for severe outcomes, this is going to be a challenging task. And we have to make sure that the vaccine reaches all of us who need it, and there is no digital divide, urban and rural divide, access divide as we roll out the vaccine.
Oh, yes, absolutely. Distribution, I think, is going to be the biggest challenge for most of the countries and their governments to ensure, and to really be ready with their plan of how they will go about it. But if I can just go across to Dr. Sanjay Pujari. Dr. Sanjay Pujari, if you look at, the details of what we know of the Pfizer vaccine so far, where they have claimed that it's, 90 to 95% effective. They've already made announcements of how much they expect to manufacture, about 50 million vaccine doses globally that they're likely to manufacture shortly. They already have a supply agreement with US. They obviously have now got an approval in UK. But the biggest challenge, Dr. Pujari, is that we were given to understand that you need to store this vaccine at minus 70-degree temperature. Now, will a lot of countries, including ours, be even able to have that kind of infrastructure?
Yeah, so the Pfizer vaccine and the Moderna vaccine, both are mRNA-based vaccines and need minus 70 for storage. What is important, two limitations of the Pfizer vaccine for developing countries or low-income countries is the cold chain facility and to store it at minus 80 is tough. But today Pfizer announced that they may be able to they have actually increased the duration of storing in refrigerated boxes from 15 days to 30 days, as well as they have mentioned that in normal refrigerator at the point of distribution, this vaccine can be stored for few hours. So that is one thing which they have amplified or expanded as something which is which will not interfere with the cold chain. But I think for countries like India, it's going to be very tough to have this cold chain. The second aspect of the Pfizer vaccine is they have priced it as $120 per dose, at least for the UK. I'm sure they may have already in talks with international vaccine initiatives and even WHO to have differential pricing for developing countries. But at this point, two doses with $20 in the UK is something which is far beyond affordable for a country like India. So I think we should be focusing on the 5 trials that you mentioned, the 5 vaccine candidates which are undergoing trials indigenously in India, and then try to distribute these vaccines if they are found to be quite efficacious and safe.
Dr. Rakesh Mishra, would you agree that, while there is a lot of euphoria even in our country and much excitement about a COVID vaccine finally getting its approval in at least United Kingdom, and that what does that mean for us? Is this a vaccine that's suitable for us or even practical for us?
I don't think we are at that point yet. Whether it's suitable for the rest of the world is also something that needs to be confirmed. We must remember these are probably safe and they have very high efficiency, but that doesn't mean that after 6 months they will not need another dose. We are yet to see that how long this protection will last. So I don't think there is, it's a fantastic scientific achievement. It's wonderful that a vaccine of this quality is already there, and we are all excited about it. But we should not put all the hopes in one vaccine or start worrying about a vaccine at this time, because none of the vaccines are having data for long-term protection, which is very important thing. Already we have to give 2 doses, and after that, if 6 months later, 8 months later, we need another dose, that will be just simply impossible thing to do. And so we have to watch out for many things. We should prepare. Even if it requires -70, at least some part of the country we can manage that. And slowly, when there is a challenge, we can rise to the occasion. And we don't have to inject the whole population. So priority can be done. Some people will anyway be seropositive after some time, so they can be, they don't need immediately vaccination and so on. So there are a lot of things that have to be put in place. To me, the most interesting thing that, most important thing that countries should plan now is, I'm sure that is in the advanced stage, is to create a system where we can monitor the data, monitor the vaccination, and digitize the whole, like first speaker said, in our healthcare system, we have to build in that so that we can follow how the vaccine is doing, and that will be very, very useful thing, not only for this pandemic, for future healthcare needs as well. So lots of positives to look for. But while this is very exciting and interesting and surprising that vaccine is ready from tomorrow, but I think we don't have to jump the gun before we know which one is better. Maybe we should put more options in our basket. Internal vaccines that are being developed or under trial, they are our best bet, depending upon how well they do. And as more and more of data emerges, I'm very happy that UK is going to start injecting this to the population, because that actually is the real trial. See, now if something in a phase 3 and the vaccine is 90% effective, you can't keep doing phase 3, because why to give water to someone or placebo when the vaccine is effective? That becomes a dilemma to do phase 3 trial of these vaccines. So I think that's a very logical thing to do, considering that it is safe. At least that's the minimum thing. But country of this size, like ours, and of the economy we have, I don't think we should be spending too much on the vaccine, which is yet to be established that it is beyond 6 months or protection. So I will be more watchful and look for the data before we can start investing heavyway. We should keep many options in our hand, and local or internally made and developed vaccines should be our preference. Unless we have provision that these vaccines we make in India, I'm sure that efforts will be on, and sooner or later we should produce RNA vaccines within the country. That is a different way.
Okay, Dr. Virender Singh Chauhan, if you want to come in as well on the first aspect, which is about the Pfizer vaccine, the fact that US is in a tie-up with them, UK has given their approval. In fact, it's such a race for the vaccine right now. Just as this news emerged this morning, we now have reports coming in, and Reuters reporting that Vladimir Putin, Russian president, has told his officials that they need to start mass vaccination against COVID-19 next week. To quote the Reuters story, it says, "Let's agree on this. You will not report to me next week, but you will start mass vaccination. Let's get to work already." So there's obviously a lot of pressure on governments, on the approval agencies, also of course on the pharmaceutical companies to get it first and to get it right. Unfortunately, we are hoping all of them are safe vaccines. But Dr. Chauhan, how do we view the Pfizer development? What does it mean for people in India?
So let me make some general comment, because specific comments have already been made. I think Pfizer or AstraZeneca, Moderna has become household name. There's so much information about them. There's overloaded information. I think what needs to be, which probably is not common knowledge, that most of these vaccines, when they are being developed in various parts of the country or of the world, the orders have been placed long back. So a large inventory of vaccines which will be made. Your question is whether India will get them or not, or should have them. Will we have infrastructure? I think if you look at the world scene, in fact, very large number of vaccines have already been placed in order for. So the first flush, like it or not, will go to the countries who can afford, who already placed it. They already have big deals. Whether it's Moderna, there are 6 more vaccines which are under phase 3 trials. So we've seen these 3. Novavax is still yet to come. There's Chinese vaccine. There'll be many more vaccines. So far, everybody worried about whether vaccines can be made, can vaccine be safe. So I just want to very quickly say that the safety issues about these vaccines, as and when we are discussing them on channels, newspaper, has been taken care of. That nobody, no regulatory agency will push any vaccine, although general belief is we brought these vaccines out so quickly. The vaccines have been brought so quickly because of amazing collaboration between scientists, between governments, between manufacturers, between producers. The most complex phase of vaccine is going to start now. So you will not have just 3 vaccines. Of course, you'll have many more vaccines. I have absolutely no doubt. They'll be safe, secure. Some will be easy to travel. Some will be easy to utilize. The problem would be when you start giving these vaccines. And I'll just make a general comment. If you have a specific question, I'll answer. That a country like India, we all keep saying that do we have infrastructure or do we have wherewithal? Tell you, India has an amazing experience of vaccination. Actually, immunization in India has been a top priority for so many years. And people may or may not realize that the infrastructure does exist. Government will put systems in place whether minus 70 vaccine should come or not. Of course, that's everybody's already answered. It will be achieved. But my suspicion, even if you have a vaccine which is stable at, let's say, refrigerator, you still have to put the vaccine in people's arm. These are intramuscular immunizations. Intramuscular immunizations are no joke. You still need trained people. And if you want to immunize, let's say, 700 million people, and you give 2 doses, you've got to put in syringe for 700 into twice, so many million times. I would worry about the dissemination of this. Of course, very poor country will have to wait another 2-3 years.
Yeah.
My final comment before I finish this. India actually is in a very strong position because you have tremendous, they are the world's largest vaccine producers. This is absolutely true. And from what I gather from whatever information I have, you can have as many as 1 billion doses next year available for India. India's, in fact, our Prime Minister promised that not only for us, it will be available for rest of the world. So CEPI, Gavi, WHO, many other philanthropists all have gotten together to worry about those who don't produce vaccines in their country and our poor country. How would you distribute to them? So I can talk for water, but if you have a specific query, my view is the most complex.
So yes,
phase of
so in
vaccine
fact, because you've raised that issue, Dr. Chauhan, let's move to the second part of the conversation, which I think is a lot more relevant to our, to us, to our audience over here as well. And there's quite a bit of, controversy and conversation that's happened ever since a comment came yesterday from the government to say, well, we never intended to, really vaccinate everybody. The idea and the priority is to break the transmission chain. And if I can actually ask you before I go to Sujata Rao about that comment that's being made. Are people wrong in saying, oh well, Prime Minister said that everybody is going to get a vaccine, and now the government is saying everybody will not be vaccinated? Was the comment and is the government's focus more on saying, well, first let's target how many people we need to vaccinate first, and in all to break the transmission? Breaking the transmission, is that the key focus?
So we generally believe, those of us who work in vaccine development believe for infections like the present one, if 60 to 70% people are vaccinated, the virus doesn't find more individual to multiply. And that's what is called a herd immunity. So let's say 10% people are already exposed and have some sort of immunity. I would say that you need another 60% of the population in a given country. If you immunize, I think that location or that country or that state or that cohort you would stop the virus infection from multiplying. And that's what we need. That's what vaccine is supposed to do. Vaccine is supposed to provide herd immunity, number one. Number two, who should get vaccine? I think this has been debated. Everybody knows that the health worker who are more exposed should get the vaccine first. I think wherever your systems allow you to quickly vaccinate, that could be a priority. But I would leave this for the government to worry about it. All I'm saying is the government or governments of all countries should make this information available for general public that this is the plan we are doing. You can't, as you said, you can't immunize people in 2 weeks or 3 weeks or 2 months. I think by end of 2021, my suspicion is you will get about 1 billion doses if you're very lucky to immunize, which means if it's 2 doses, 500 million people. That's the most optimistic estimate. I would say some countries will have to wait till 2022,
Okay.
2023.
Well, that's an interesting, comment that you've made, and that timeline. And I think not many people understand, but I keep emphasizing on that this could take a really long time for some people to get the vaccine.
Sure.
ICMR of the vaccination process has said, and I just want to quickly go through those comments which the ICMR has made, which says vaccination would depend on the efficacy of the vaccine. Of course, the purpose is to break the chain of virus transmission. If virus transmission is broken, we may not have to vaccinate the entire population. Want to make this clear that the government has never spoken about vaccinating the entire country. Dr. Sanjay Pujari, help us understand this. When it says that we are not talking about vaccinating the entire country, there is a fear. How do you decide who gets it and who doesn't?
Yeah, so when we talk about, as was mentioned by the earlier speaker, we are looking at for breaking the chain of transmission, trying to develop a herd immunity. And herd immunity actually is a complex phenomena. It's not a very easy percentage that you can determine based on because it varies based on the transmission dynamics, the geographical areas, etc. But roughly, some months ago, we were all really fascinated with this metric called R naught. And herd immunity actually can be calculated from R naught. But it is something which is based on an assumption that other mitigation is not happening. So people are not following social distancing and things like that. So this is a really complex thing. The other issue also is that we now understand, at least from the transmission dynamics, that COVID-19 seems to be transmitted more commonly as a super spreading event. So essentially 20% of people are capable of transmitting it to 80% others. So it's that those super spreaders in super spreading situations which really contribute to majority of the epidemic. But of course, it's very difficult to find super spreaders, and we can't really go and vaccinate super spreaders only. So essentially, this is a complex phenomenon. I agree that if you look, assuming that in addition to mitigation, wearing masks and things like that, if you're able to vaccinate around 50% of your population, you may see a dramatic impact in trying to control this pandemic. But again, we can't have a ballpark figure for the entire country. Each area is different. The epidemic has been different in terms of severity in different geographical regions. Background immunity, exposure, herd immunity because of natural infection, all those things have to be considered when we talk about herd immunity secondary to a vaccine. To really end here, I think it is complex, and we need to prioritize first and try to perhaps focus on the limited vaccine doses that are available in trying to reduce morbidity and mortality to make this accessible to the target groups which are most vulnerable to get infected and get sick and perhaps die because of this illness. So that is the priority group that we need to focus on, and that essentially has been focused on
Okay.
for the first few rollouts
Sure.
across the world.
Sure, absolutely. But Dr. Mishra, just to emphasize on this again, because there is a lot of concern with a comment that was made, and I think a lot of people don't understand the point behind it, as you experts are pointing out. The percentage of the population is what experts look at for, for them to be immunized, and that essentially should help us stop the transmission or break the transmission. So it's not necessary that as soon as possible we get everybody vaccinated.
Yeah. I mean, this is, to vaccinate everybody in a way means to protect everybody. You can protect everybody by vaccinating maybe half the people. As you just heard Dr. Chauhan said and other speakers said that you need to achieve the herd immunity, which means some 50-60% roughly of the population you need to vaccinate. We are already having so many people, we know by testing, so many have not been tested. So that is why we need to do lots and lots of serological survey, figure out what is the percentage of population, and then we can have better planning. One way can be that do serology. If somebody is negative and is at a risk, needs to be vaccinated. Those who are seropositive, they are naturally probably immunized. They don't need to be. And so far we have seen the reinfection is extremely rare in this virus. So we are lucky in several ways. We also know that most people are asymptomatic. So in fact, we should only focus on those who are at risk. And considering that lots of people are already getting natural immunity by natural infection, and many of them are going to be asymptomatic anyway. So we have to use planning and these kinds of data analysis and use the vaccine where it is more effective.
But how do you use that, Dr. Mishra?
Yeah.
How will you use that information? How does a government or any authority which is in part of that or in charge of this mass immunization program, how do they use the information available about people who did get infected but were largely asymptomatic, and obviously their bodies found their own ways to fight this virus and perhaps they don't need the vaccine? How do you really use this data and sync it with your immunization program?
No, I'm not saying that the people who are asymptomatic don't need. That is our. That's why those who need more is the people who are vulnerable. So those who are aged and have other kind of complications.
Okay.
What I was saying is that our vaccine plan should be in such ways that it is supported by serological data. So if somebody is having seropositivity, doesn't need the vaccination, and so we can plan those things in proper way. I'm sure the government is doing that. Vaccinating everybody may be a waste of resource, and we may be spending resources where it was actually not required. The whole purpose is to stop the pandemic, stop the spread of the virus, and that doesn't mean that in one city you vaccinate everybody and other places nobody gets the vaccine. So that's why lots of planning. I'm sure government is having at very high level lots of strategic planning done by this, and that's why the statement came yesterday that this is technical and scientific issue. It should not be used for political reasons. So the vaccine is a very good tool in hand. We are talking a lot, but I must say that we already have our social vaccine option of mask available to us. That's what we should use. If we can do that, we can avoid vaccination for quite some time and let those who are needy and healthcare workers and other who are higher in priority list, they should get first. So we should have a comprehensive plan, and we should not treat that vaccine as something which everybody needs as soon as possible. We can manage without that in a reasonably.
I was going to read exactly that point, Dr. Mishra, and I was wondering about it, and I'm glad you made that point because I wanted to ask that question. Maybe I can take it across to Dr. Brahma Mukherjee also. Dr. Mukherjee, would it be right for any country, and even for India, to pin all of their hopes on the vaccine, for people to believe that this is the the beginning and the end of all of our solution for our big problem? Does a country need a more exhaustive strategy to fight COVID?
So first of all, I'd like to clarify that the vaccine and the endpoints that have been evaluated in these trials is really symptoms and disease, not infection. So it could still be that you are infected and you can transmit the virus. This is an important point that has been missed a lot in the media. So I think that until large number of people are vaccinated, even from a vaccinated person, the virus could transmit. So we do not know enough data on the infectivity. We only are looking at disease and as a secondary endpoint, severe manifestation of the disease. Nobody is getting tested every day to get the asymptomatic infections. So I think that the mask wearing, non-pharmaceutical interventions are still going to be in place until we have reached that threshold where we feel that not enough people are symptomatic and transmitting the virus. The second thing I want to mention that often we forget to give credit to the infrastructure of low and middle income countries. I am in Calcutta right now, and I can tell this on national television that it was easier for me to get tested in India than in Michigan. So I think that in the last 8 months, you have seen incredible escalation of RT-PCR availability, and the public-private partnership has really worked in India. So the string quartet of the public, the private sector, and the government and the scientists has worked in concert to make tests accessible and the tests cheap. Neighborhoods are having free testing. You have bought buy-in from community leaders and religious leaders to intercept into hard to access communities. So this has happened at a grassroots level for testing. So I don't see why this cannot happen for vaccination as well. So the first pass at the mRNA vaccine is hard because of the storage and the quantum that you need, but there will be other vaccines, and we really need to think about this strategy. And I think that things are active, conversations are happening, and I am hopeful that we are going to battle it just like we have seen a tremendous escalation, and I'm hopeful.
Okay, always good to have, voices of hope and optimism also as we bring about these facts as well. One aspect that I wanted to raise, and Dr. Chauhan, maybe you can come on this, is that many say we still don't know how long the effect of any of these vaccines would last. We don't even know whether those who, whose bodies found the immunity themselves and generated the immunity and the antibodies themselves, for how long do they last? Is there any more light you can shed on that? How long do the antibodies last? How long would a vaccine of this kind really last?
I think we mustn't forget that we are still halfway through the pandemic, or halfway, maybe 1/4 or 2/3 way. Lot of questions about the structure, immunity for the virus we know. But what we don't know about the COVID immunity is much more than what we know. So we must not, we can't be asking the question of how long the immunity will last through a vaccine, because we haven't vaccinated large number of people. These results will come out as we grow. And many other questions, whether neutralizing antibodies are being produced or not. And I think Dr. Mukherjee already said that people seem to forget that Pfizer had said the vaccine will protect you against severe disease. So clearly you can read what they're saying, that you still might get infected. So I think all of us have said more or less the same thing. We need to be extremely cautious. This is the time when we should be even more cautious than before, because this hope and the discussion might give a false sense of security to the population. But the question that you ask to us directly, we don't know. We don't. What I hear from my information, that many people have got infection and have not produced antibodies, or have produced very low titer antibodies. So can we answer the question that you're asking? I don't think we are ready to answer those questions. Very large number of people, will have to follow them up in a longitudinal way. If you ask this question 6 months now, 10 months, mota we know, broadly we know that immunity, the antibody and T cell responses might last at least 5 to 6 months. Immediately you'll ask the question, what happens? Should we immunize you again after 6 months? There are no answers to these questions. And this is not the right time to ask and answer those questions. We don't know. Many things we don't know.
No, so in fact, the intent of me asking this question was exactly to highlight that we don't know, and because a lot of times people say, oh, well, 3 months ago or 6 months ago, we said something else, The government said something else. WHO said something else. The experts, said something else about any of the treatment drugs or any of the vaccines. Now you're saying something else. And 6 months later, it could be something else. But that's also because it's a new virus. It's a novel virus. We are also finding out things as we go along. Scientists and experts, day in, day out, researchers are looking at this and collating as much information as they can. But there are still a lot of things that we don't know, including how long will the impact of any vaccine really last. Dr. Pujari, as I say also good evening to Sujata Rao, let me first come to you, Dr. Pujari, on this aspect. The fact that even if we do get a vaccine that India approves and we roll it out to begin with the priority groups, we will have to track them, for several months. How long will we have to track them to see whether the vaccine is, protecting them, and for how long?
Yeah, so once you really give a dose of the vaccine, and we assume if it's the Oxford vaccine, it will be 2 doses. For efficacy and safety, you need to really follow them up for years together. Because one is, of course, you should also parallelly try to do immunogenicity studies. Those are things in a small population, apart from the outcome of clinical disease or infection. So this is kind of going to be a phase 4 study, and it goes on for a long period of time. And this needs to be kind of a surveillance where you need to properly address this. Simultaneously, you would obviously have this vaccine being rolled out in various other parts of the world, and we can have information from those parts of the world also about the safety and efficacy and the long-term issues associated with this vaccine, and try to really use that information in trying to make this vaccine, judgments about this vaccine in our country as well. So, as was mentioned by the previous speakers, we do not know the duration of protection. It is believed that it's not just the antibodies, but even the T cell immunity, which is supposed to be long term. We have some good examples from the previous coronavirus infections, like the MERS and the SARS original Hong Kong virus, which seem to give you protection for a period of about 1 to 3 years after natural infection. Obviously, we don't have vaccines for these two. So we are just extrapolating. We need to wait. We need to look at good quality data and then really conclude on the efficacy or the long-term protection or safety of these vaccines.
Okay. Sujata Rao, good to have you with us. There's a comment that we were earlier also discussing, and I wanted your view on it, with the ICMR and the government saying that, well, we didn't say that everybody will have to be vaccinated. Our focus is to break the transmission, and that's what it is. Now, this has triggered some amount of questions on whether there will be selection of who gets it and who doesn't get it. Can the government really decide on who doesn't get the vaccine, or are people getting it wrong and it's merely a priority list and everybody at some point can get the vaccine? How do you view this comment that has been made as far as policy making is concerned?
There are two aspects to it. One is that considering that there are just that many vaccines available, some amount of prioritization has to be done by the government. That's only natural. So they will go in for the health workers, the caregivers, whether in the public and the private sector. They will have to be vaccinated first of all. The second question that comes in is breaking the transmission. And that, I believe, will be guided hugely by the epidemiological data. Who have been most vulnerable to morbidity and mortality on account of COVID in India? Our demographic age structure, as you know very well, is very different to what we find in the US or Italy or European countries. So it's the elderly people, or like say, take Sweden. It is the elderly people who are dying most and are most vulnerable to this infection. But maybe in India, now we have enough data since we have treated so many people. I do believe that the government must be looking very closely of the data of treatment data and the type of people who have died, both in the public and private sector, to come up with some kind of a typology of the kind of people who are more vulnerable and susceptible to this infection, and they will have to be then culled out of the public and be given the priority on vaccination. So that's the only way they'll be able to stop the transmission. Having said that, there is also a broad thinking that, since a lot of 30 to 50-year-olds or 40 to 60-year-olds have died or been susceptible to this infection, is it really adequate only to think of the elderly, who are only 8% of the population, ignoring these people who are working and productive age groups who are going out into the community and possibly spreading the infection there and bringing it back home also. So this entire age structure, the type of population that is exposed will be driven largely by epidemiological data. My only hope is that this is being triangulated well by the government, and I'm sure it is. And then they will take a decision. But I do believe what they have said. Not all the 1.3 billion people have to be infected right away. And in any case, they can't. We don't have either the wherewithal or the infrastructure to do it simultaneously. It'll take us a good 2 years by the time the last person is reached. So, what earlier speakers have said, I would advocate for caution. I would not want to fall into this hype for the vaccine. I would say try to live with the disease as naturally as possible by taking all the precautions, rather than thinking that vaccine is going to be the panacea.
Okay, it could take 2 years for most people to get it is an interesting point. Dr. Pujari, do you want to comment on the other aspect that Sujata Rao raised about the fact that while there is a larger sense that yes, you need to protect the vulnerable groups, the elderly, the senior citizens, and those with comorbidities, have there been a lot of cases that should raise a concern even amongst youngsters, severe cases, and even fatalities? Do we have any exhaustive national, trend in there?
Yeah, so if you look at the clinical profile of COVID-19 patients, by and large in the country, it really reflects what is seen across the world, that elderlies with comorbidities are the people who are most vulnerable for mortality associated with this disease. And there is actually a linear gradient of decades and mortality. Fortunately, in India, as Dr. Rao mentioned, that we don't have very elderly population. In Italy or in the US, you have people who are more than 80 years and 90 years, very commonly seen. So they form a significant proportion of the population. The mortality in those population is almost up to 20% with COVID-19. So it's high priority that, in those countries, you need to really take care of these elderly population. But having said that, if you look at mortality amongst younger population, and if we talk about 40 to 60 age group also, there are two important other clinical factors apart from age between this 40 to 60, which makes them vulnerable to mortality. It's not just the lower age, but also obesity. Obesity is one of the bigger risk associated with mortality amongst these younger people. And in India, we know we have this very classical abdominal obesity coming up in this age group as you age around 40, 45 years. And that is really making people vulnerable in this age group. It's not just the age, but obesity associated, abdominal obesity associated with that age, a higher BMI. And the second is, along with this obesity, people start developing comorbidities like diabetes. The prevalence of diabetes is extremely high in this age group. So I think it's not just the age group, but comorbidities, obesity. If we have ability to really cover this population, in addition to the elderly population, without or with comorbidities, we may be able to make an impact on the morbidity and mortality of this virus in the initial phase of the rollout.
Okay, that's an interesting point that you make. And, I was just looking at the plan that UK has, at least for Pfizer vaccine, for them that has been given the emergency approval, that they will first look at priority 1 is residents in a care home for older adults and their caretakers. Priority 2 is those above the age of 80, frontline healthcare and social care workers. Then priority 3 will be everybody above the age of 75. Priority 4, clinically extremely vulnerable individuals. Priority 5, all those above the age of 65. Priority 6 is individuals 6 to 64 with underlying health conditions. Is that also, are we also looking at a similar list, Dr. Mishra? Should we also then weave in people, and I don't know where we'll find the data, but obesity or diabetes and with those kind of conditions, how do we include that as part of our policy for immunization?
Right. So you just said that even a country like UK is not going to inject everybody in one day and in one go. So that's going to be, so this is really a complex issue. Like I just heard that one strategy may be to target super spreaders if we knew very active people who are going, even if they are going to asymptomatic, they are going to be spreading and eventually it will land in to people who have a comorbidity. So I think this is a highly technical thing. We lack data. That is one of the problems we have. All the data is not digitized. Most of the things are not recorded. So there will be difficulties in that. But that is why I was mentioning that this is a good occasion for us to create database for our people, link it to their IDs, and then follow them up. There will be lots of discussion, debates. It's simply said because we don't have enough resources of vaccine and financial resources to inject everybody. So we have to use certain criteria. I'm sure government and policymakers will use the experts and whatever data we have available and generate data. As I was mentioning, do lots of serological testing that is now feasible. Do many other kinds of estimates and then target the people who will be most crucial in stopping the spread of the virus. And at the same time, we continue what we are asked to do now, which is to wear masks and keep crowding and at least inside a house, in the closed areas, less number of people and so on. So in this way, we should not think that the final thing has arrived and we have to make all our things based on that. Things will change. Early next year, new vaccines will start coming and those things will change the scenario. If this is easy to administer and easily available, why not inject more people? There is no problem. But the return of investment on those things, a very large number of vaccination, is not that high. Simply said, because we cannot fast forward time, so we do not know how long these vaccines will be useful. So we have to take many things into consideration and see that what can be best to stop the spread so that our economy gets more on track and the people's life becomes easy, because that has been a bigger problem, than to sometime into the medical problem. So there are many aspects to it. So I will say that minimum number of people that are required at this stage for breaking the spread, they should be targeted and not the whole, because I'm not sure how long this vaccine effect will last. And we should depend on the more reliable and the known methods right now, which is the mask, and that's what we have to convert. That the time has not come that there's a tablet, there's a vaccine, and now you can just start freely moving around. It's difficult to do. Malls and restaurants and those things are crucial for economy, and then mask wearing there, and there are difficulties in that. So that's why we have to consider many factors and then make a strategy and do it. Now slowly vaccines are coming, things are very dynamic, it will change. Safety data, more and more safety data is required because it might be counterproductive with this much of data.
Okay, let me ask you this question, Dr. Mishra, then.
Yeah.
For how long? And I want to ask this question because I think people also need to get a sense. Say in March and April, Dr. Mishra, that's when we first started having conversations with you, and we spoke about social distancing, we spoke about isolation, and it was unimaginable then to say, oh, this entire year, this is what you will have to do. This was, even before the government had actually announced the 2-week lockdown. Now you're saying that even if, we shouldn't focus so much on getting a tablet or even a vaccine, and just continue the way we are fighting COVID right now, which is still maintain our distance and wear a mask. But for how long? Should we prepare ourselves for 2 years, 3 years?
it's very, very difficult to make such prediction. I didn't say that not to focus on. There are people, there are the government and system companies, they will do it. I'm talking about for the common people, what hope they should be given. They shouldn't be told that now the end has come.
Yes,
and
absolutely. I mean, from our own mindset perspective, what do we pin our hopes on?
We should be prepared to live this disciplined way or with mask and these things for at least next 6 months. After that, if vaccines start to work and herd immunity starts to kick in, then might be something different. But I might be wrong because it all depends on the way social interactions, how many people, weather and these and closed rooms, and lots of, there are so many variations of this. So next several months, we have to be on the guard in this way. That's my guess.
Okay, Sujata Rao, let's just say that, as experts have also been pointing out, that manufacturing of some of these vaccines has already begun. Pfizer already has agreements with various countries. Our manufacturers are also looking at it. Even if you're able to say, to begin with, put a decent number of millions of doses available in the market, how long will it take, or in the first 1 year, how many will we be able to immunize, keeping in mind the current infrastructure, the current system that we have in place?
It's a very difficult question you're asking, Tanvi, because it's not Pfizer alone. Pfizer has a limited capacity and they're going to do 100% of production. And there are lots of people going to ask for it. It's expensive. It's a vaccine which India cannot afford to have because of the storage problems. And Pfizer is not an easy company to deal with from my experience of H1N1. They're very stringent MOUs and pricing is very difficult to negotiate with. Having said that, I think I have greater confidence in much more affordable vaccines coming into the market by about April, May maximum. And that will be much more sustainable for us to have to bank upon rather than chase Pfizer. So I think there's so much research being done. It's so dynamic and so volatile that I'm quite confident that it's not the first vaccine which is going to be the best. I think the subsequent ones, there's much more information, research coming in. They'll probably be much more resilient, much better quality outcomes will come of it, and they'll be much cheaper therefore they'll be much more sustainable for India to take on. So the point here I just want to leave you with is, please do remember that vaccine manufacturing capacity is limited in the world as a whole. We are not prepared for 2 doses to cover 7 billion population in one go. That means 14 billion vaccines. No, we don't have that. So it is. We also have to take care of the manufacturing of all the vaccines that are vaccine preventable diseases as well. So there is only that much that can be done. There's only that much of carrying capacity for the public system to be able to take it forward and inoculate the patients with. And there is also the third dimension of patients willing to take the vaccine. Just imagine if tomorrow, let us assume, for whatever reasons, the infectivity rate comes down. Say in 6 months' time, you hardly come across many cases. I may be in a comfort zone and not want to take a vaccine. So it depends on the people's perception at the point of time whether they want to get themselves vaccinated for an infection that might have disappeared, like H1N1 has. So let it be lots of ifs and buts are there.
Yeah.
I to put a figure.
Well, in fact, a study that was conducted by MIT, Johns Hopkins University, and Facebook, and they did it in multiple countries, and that survey that they conducted showed that 10% of their respondents in India said they don't want to take the vaccine. The number varied from country to country, but that, largely globally, that was the percentage as well. That being said, that will, I think, be at a much later stage in our fight against this pandemic. But Dr. Chauhan, very quickly, also on these announcements that are coming in from Russia now, since we are in partnership for Sputnik trials as well, the Russian president has asked his own administration to start the mass vaccination program for next week. Is this a candidate that we should seriously be looking at as well?
Well, as I said, let me very quickly say the 6 more vaccines which we haven't talked about, Moderna, AstraZeneca. Two very quick points. AstraZeneca and Oxford, when did the deal, AstraZeneca agreed to roll out vaccine for countries free of, there's no profit made. This is the contract. So no wonder AstraZeneca will be more affordable. I think we're missing out on AstraZeneca as a possibility. Will be made in India. The 200 million doses were already made. So I think Pfizer talk is fine because Pfizer is been approved very soon. This is my gut feeling. The 6 vaccines which are under phase 3 clinical trial would start coming out with the data. These 2 came out, or 3 came out first because they were really off the block before anybody else. But others are following very closely on their heels. So you would actually have, so we are actually walking ahead of ourselves right now. We would have a choice to look at, to my mind, this is my, I'll stick my neck out. You would have at least a dozen vaccines to choose from, at least half a dozen to choose from. There will be affordability issue, there will be the transportability issue, there will be how many doses will you give, etc. All this, I think, very soon in short time. Only thing I want to stress to the public here that we mustn't feel because these vaccines have come out very fast, therefore any compromises have been made by their safety trials. Safety phase 1 trials have been done very stringently. They have been published, the information available for anybody to look at. So what our duty is to say that nobody is dropping their guards by bringing the vaccine out quickly. I think that information is extremely important. So please, nobody should fear that because of A or B or C of economics or this thing is being rushed. That will not be true. So, and the vaccines, let them come. They will come. I think we could have a conversation 3 weeks now. You might have another 2 vaccines you'll be talking about. As soon as that, in that much time, you will have the choices. India is in a unique position that you have many phase 3 trials going on. Our production ability is fantastic. I can give you the numbers. There are amazing numbers that India can produce. And I dare say the very large number of people in poor country will get immunized because India would be in a position to produce these companies, as we've done for all other vaccines. So let's just calm down on this Pfizer or any front runner. They are excellent news. They deserve the attention they are getting, but let's just wait for a while.
Okay, let's wait for a few more weeks. And I think I just want to highlight, like you did, that outside of Moderna and Pfizer, there are others, especially the 5 ones that India has partnered with, including the Oxford AstraZeneca trial, including our own Bharat Co vaccine, and 3 others that are currently for which trials are underway in our country, the ones that we would watch out for. Since we are in conversations at a government level between India and Russia, it will also be interesting to see what the Indian government has to say about the Russian announcement that came in today. Big thank you to all of the panelists who have joined us right now. Viewers, let me quickly summarize this for you. Yes, it is good news, as our experts were saying, that at least one Western world country has begun with an approval for emergency use of this one vaccine, but that's not the vaccine that's ideally suited for us. And since there are a lot more candidates which are very close to the end point and then getting their approvals, it is possible that the government actually waits for one of these vaccines and their trials to end, for those details to be submitted, for the tests to be conducted, for the stringent checks to be done, and approval to be given, all on a fast-track basis, but perhaps not Pfizer or even Moderna. And we will bank on some of the others instead. That being said, it still doesn't mean that you will get the vaccine overnight. Suffice to say, you shouldn't get too worked up about the comment that came in from the government that when did we say everybody will get the vaccine? It's not to say that they're going to choose that you get it and you don't get it and you get it and you don't get it. That's not what the government is going to be doing. The government will prioritize, will give it to a certain set of people who are either more vulnerable or out there in the front line as part of their professional demand, which is why they need to be protected first, and then it will be rolled out to everybody in that order. What the government possibly means is that we only need to immunize a certain population of our country to break the transmission chain. The immunization program for COVID will continue if we find the right vaccine even after that. Thank you so much for joining us on this conversation.